So good afternoon, everyone. We have the pleasure of being the next to the last session, the penultimate session in this forum. My name is Kathy Luther, and I'm here with two colleagues, Roger Resar, who you will hear from later, who's a physician at the Mayo Clinic and a longtime fellow at IHI, and Neil Romanoff, who will really tell you how this worked in his organization. He's a physician and a chief medical officer at Cedars Sinai in the U.S., in Los Angeles. I want to tell you a little of the history of how we got to this point, and our talk is called What Will Go Wrong Next? So we might have a slide. The interesting thing about what happened is Neil Romanoff called us at IHI and said, you know, we're a big organization, we pride ourselves on our quality and our safety, and we try to do things as top of the line as we can, but we still keep having errors. Can you help us figure out what will go wrong next and how we might know what that would be like? So one of the things, can someone get my slides up? No? So can you put them up there, Roger? Sorry. So it was interesting as we began to think about this and how will we know? That was easy. We decided that we would really, what are the things that we need to know about before we go into an organization who's doing things very well to learn about what might go wrong next there. We've divided this presentation into a couple things. We're going to give you the theory and the framework behind what we did. We're going to talk about how we implemented it. We were going to have a learning exercise, which we will not do given the size of this room and the length of the presentation. Then we'll have a little time for questions and discussions after that. I think it's important to think about the framework, how this went about, and to hear from Neil about how we actually implemented this in his organization. This really goes along with the talk this morning about normalizing deviance and high reliability that we heard from astronaut Dave Williams. And we wanted to show you how organizations can develop a systematic approach within healthcare to begin to think about this. Our framework came from another colleague, Steve Spear. His book is called The High Velocity Edge. He spent a lot of time studying Toyota and the Toyota model and how they've developed reliability, and he works to bring that into other settings. One of them is healthcare. He was our partner in beginning to develop this. This is a busy slide, and you can download it from the website, but the interesting thing about this is he started to talk to us about levels of maturity in quality. And he started to say, you know, some organizations are down there at the bottom at zero where things are just happening every day. People are just making it as safe as they can. There's no systematic approach. The next level is really interesting. He calls this buffers. And what happens there is people make things work in chaotic situations. And on a nursing unit, it might look like a charge nurse or a physician has a very standard way of working. And people know when that person is on, things will go very well. But when that person is not there, or in transfers and back and forth with other units or other areas or transitions, things may not go well either. And they call it buffers because people sort of begin to hoard things in these situations. So they'll hoard staff, they will hoard supplies because they don't trust things will get to them in time. The next one is called a spectator. And what happens in that is a spectator level. People come in and do it to an organization. So if you'll be talking to somebody in a lab, they'll say, oh, the Lean Six Sigma people came in and they did all this, or the IHI people were here and they did all this, and now we do it this way. The next level is the kind of spectator times 3, where we keep redesigning the same processes over and over again, but the staff aren't so much involved. They're more like spectators. The next level turns up to be really a leadership activity, where the leaders become involved in not only the microsystem work, but they deeply begin to understand how the microsystem works and what they can contribute to it. And finally, and this is where Neil was actually looking for our help as we began to understand, how do we embed that work into the staff in their daily work so that they understand how to do it, and the leaders are actually more facilitators of how that begins. So we thought there were some characteristics that we learned from our colleague Steve Spear of highly reliable systems. They're really designed well and they operate well. We heard this morning from the space shuttle. There's a lot of problem solving that goes on within them, and risk mitigation and management. People share knowledge. Somebody knows about this, but in other systems they don't necessarily tell other people what's going to happen, and the leadership is extremely engaged. You saw all these principles this morning in the talk you heard. What we thought about this is, as we said, high reliable systems, as we brought this down to a unit level, people actually see problems. We found out we were pretty good at seeing problems, and you'll hear more from this from Roger and Neil. People see problems every day, but often they don't take the next step to actually solve the problem. Oh, this happens here, it happens all the time. Here's how we mitigate against it. Here's how we fix it. Here's how I keep supplies when I know we won't be able to get what we need. Then they share the knowledge laterally. They tell the next shift, they tell another unit, they tell someone else the problem that they've seen, the problem that they've solved, and who else it might affect. And leaders lead not by necessarily edicts, but actually beginning to develop these skills in their directors, in their managers, and beginning to develop them in their frontline staff. So this begins the theoretical framework that we approach this by, and I will turn it over to Roger now, who will really talk about the details of how we began to think this through.
Good afternoon, colleagues. We've actually had a wonderful journey with this idea, and sharing this with you today is, in a short period of time, fairly difficult. We did include in the packet that you can download a document that describes in detail this methodology, how the methodology was developed, and why the methodology was developed. In essence, as the IOM report has stated, in the last 10 years, in spite of the fact that we've been working on safety in our organizations, there hasn't been much change in the degree of safety that an individual patient experiences in our hospitals. We know, for example, that across the world, in every hospital we've tested, about 30% of patients have an adverse event. And that has not changed in the last 10 years. The vital question is, why? The vital question that Neil asked is, why do we keep having these problems? And at the same time, we are world-class performers in many of the projects that we've been working on. How does that mesh? What we needed to do is come up with a methodology that actually exposed, in a real-time situation, exposed the risk that your organization is experiencing on a day-to-day basis. So we developed something called a frontline defect-driven project model. And I'll go into detail about this in a minute, but specifically, if you're interested in the methodology itself, there is the handout that you should download. But what this particular slide shows is that there is this stream coming up from the front line. This stream represents all of these defects that our front line works around day after day. They have worked around these defects for so long that they consider it, this is the way we do our work. And it never comes to the forefront as a major problem that leadership will take on and try to fix. What happens is, as we understand the methodology of something called a frontline structured conversation, we learn how to surface these particular defects in a way that we can actually have the front line continually improve the work they do based on the understanding of these defects. We look at both clinical and non-clinical frontline defects. And eventually, because we know how to identify the defects, we collect data about these defects, we have the front line suggesting strategies about these defects, we end up getting engagement of the front line in a way that we never imagined, leading to, of course, small tests of chains and projects. So this is the model that we've developed. It's highly schematic, obviously, but the nitty-gritty is in this slide, and the real methodology, if you are interested in this kind of work, is in the handout that that you will have the opportunity to download. Now, what's unique about this methodology isn't that there's improvement. I think we all do that. What's unique about this methodology is the way the defects are surfaced, the way the front line gets engaged, and the fact that the project's aim is to finish in 30 days. And this is done without a major team. This is done with one or two individuals, although a team certainly can be part of the program. What we see here is on the top, a timeline. Tells you how long each one of these steps in the flow take. We look at the benefits of this particular methodology, and you will see a lot of front-line engagement, tester engagement, front-line engagement, but very little leadership engagement here because it's not needed, except in some very small areas. The specific actions that we have designed in this methodology starts first with surfacing the defects. There's a specific methodology that was developed at Cedars Sinai when we visited their hospital, and this specific methodology outlines in steps clearly what needs to be done. We use something called a conversation with the front line. This conversation involves using anchoring questions. And one of the common anchoring questions we would use is, do you have ever a bad day? Of course, everyone has a bad day from time to time. Now, once you understand that, yes, I had a bad day, tell me why your day was bad. In that conversation, what we end up finding are the specific areas that the front line are making accommodations for time after time, but now consider it part of their work rather than an actual project that needs to be improved. These anchoring questions, when applied in the conversation that I'm talking about, will in a 90-minute frame surface anywhere between 12 and 20 defects for any given front line that we have the conversation with. I have been carrying out these conversations at the Mayo Clinic now for the last 6 months, and we have yet to not surface at least 15 to 20 defects in that period of time. Now, surfacing the defects is relatively easy in terms of the methodology that we've developed, but there has to be something that lends these defects to improvement, so that's the next piece of the action on the flow diagram here, and that represents scoping the defects. There are some defects that are out of the realm of the front line to work on. For example, if they're unhappy with the computer system, that is not likely something that they're going to be able to work on. So it becomes extremely important to scope these defects in several ways. First of all, we align the work that might need to be done with the strategic goals of the department. This is how we get the leadership involved. We gauge the capacity for the front line to actually do the work. We articulate the implications of the work. Does it interfere with another department, or is it unique for your department? And then we study this in such a way that we actually scope the project and say, yes, this is a project that you can work on the front line with 1 or 2 people, because it doesn't affect the rest of the hospital and it might make your day better. So that's the effect of scoping. Again, the benefit is that you engage leadership because they see how it connects with some of the work that they are actually inclined to do. Now you see the timeline. The conversation takes 90 minutes. This scoping, we allow about a day or 2 for this to happen. We then go to the next step, which is called validation. When someone tells us that it's a defect, we assume it's a defect, but we don't know how serious it is, how much volume is actually occurring with this particular problem. So we need to validate it. And we validate it in a very simple way, without using much resource at all. We will set up a simple yes, no, and then ask the simple question, did this happen? Yes or no? If it doesn't happen with enough frequency, it's not something that's probably worthwhile working on at this point. So this validation becomes extremely important in determining that this is worthwhile to spend even our limited resources on. This validation engages the front line because they see the frequency with which this defect is occurring in the organization. The next step in the flow diagram is selecting the specific work that needs to be done. Now this becomes very important because it defines the boundaries of the work. If you do not define the boundaries of the work, what can occur is you end up having a project getting larger and larger, and this is not what we want to happen. In my experience in using this conversation, we encourage 1 physician to work with 1 nurse or 1 ward secretary or 1 receptionist to work on a single defect. This is the smallness of it. There are no teams. Basically, it is working through these small defects. Now, these small defects, once you define the boundary that you're going to be working around, you determine some very simple measures that you would use to determine whether there has been some success or failure with the work that you're doing. This is how we engage the tester. The tester is usually going to be a frontline person who is going to try a new strategy tomorrow to see whether it improves this person's day. Now, that takes about 60 minutes or so to actually define the boundaries and to start doing some of this work. The next piece in the flow diagram is to design the strategies. Now, what's unique about this particular work is that the strategies that you define are strategies that come from the front line. The front line says, this is what I think will work, and we will then try these strategies in a very small test of change the next day. We allow the team to work approximately 30 days to finish their project. Now that's the methodology. Of course, there's customization to this, there's some leeway, but what we're finding is this fairly rigid methodology is the best way to ascertain that the front line stays within the domain that we want them to work, that they don't make the project larger than they can do in 30 days, and that we have very simple measurements that do not require large-scale data collection in any way, but rather simple paper collection that says, yes, it worked, and no, it didn't work, or whatever the case may be. So, I have not described in detail each one of these steps. I've given you the highlights. The paper that you can download actually has the highlights and the in-depth description of what happens at each one of these points in this framework that I've just described. Now, as an advertisement, and I'm not sure that this is absolutely kosher, but I want to tell you that in a few short weeks we are going to be starting a Web in Air, Web in Action series at the IHI, in which we are going to have 3 learning sessions where we will actually walk you through each one of these steps, making sure that you stay true to the framework. So stay tuned for an announcement on this that you may or may not find appropriate for your work. Now, the bottom line for all of this, can you actually create change? If you recall, and I don't remember the numbers exactly, but when you recall the Toyota production model and you start looking at the number of changes that occur in the front line in a given year is measured in the thousands. Of those changes that occur in Toyota in the production line in the thousands, 99% of those are driven bottom up. And a very, very small percentage are top down. What we are trying to do is emulate in healthcare a lot more of the bottom-up approach to improvement, and we think that's through understanding and surfacing and then having a methodology to deal with those small defects, those very small defects that make a day bad for a particular employee. So to describe some of the work that has actually been done with these sorts of groups on frontline defects, I'd like to introduce my colleague, Neil.
Okay. So as Kathy alluded to, this project started when I had a conversation with the CEO, and that followed an event at our institution that is now well known related to CT angiograms and exposure to excess radiation, which we didn't know we were doing. We didn't know what we didn't do. And as that event wound down, the CEO said to me, "I don't want to have another one of these." And I said, "What do you mean?" He said, "Well, we didn't have any of this on the radar, so how can we do some work to sort of learn what we don't know?" And what went through my mind almost immediately in that conversation took me back to my early IHI training, which was, oh, this sounds like an FMEA at the institutional level. And then the next thought was, well, that's overwhelming. And then that led to a phone call with Maureen and Penny Carver at IHI and this project as a way to sort of look out there and discover what we don't know. So as was mentioned, we think we're a world-class organization, and we keep having events. We keep doing improvement cycles, things get better, our mortality's great, our CLABSIs are great, our VAPs are great, and then every once in a while something comes out of left field at us that we had no clue about. So the question was really to move on to evaluate how we were doing hazard finding, and that led to an on-site visit with Steve Spear, Roger, and Kathy, during which we visited several areas in the hospital. The challenge was not to find the one big bad thing that was going to lead to the next event. The challenge was back to the Swiss cheese theory and asked us what were the little things that were going to line up and lead to the next big bad event. And somewhere those were going on every day, along with, as Roger said, it's these little things that have become normalized in everyone's day. So Roger and Kathy and I and Steve and a handful of my safety people scheduled over 2 days a series of 90-minute visits to a number of areas. We went in, and as Roger described, we started to ask the probing questions about sort of what drives you crazy, what made the day evil today, what did you plan to do this morning, and what did you actually wind up doing? And if they're not the same, what interrupted that? And one of the things we learned pretty quickly about this was that it was actually easy to get people to talk about this because this was not part of an RCA. You weren't asking the questions after something bad happened. So nobody was circling the wagons, and people were talking pretty freely because nothing bad had happened, but they had observations to make. So to make it interesting, we didn't just go into clinical areas. We went into these 6 areas. So we went into a pretty blue-collar clinical engineering area, and they were the first to tell us something that we heard in many places, and that was when you find something out of the ordinary, what do you do? And we have an incident reporting system called MIDAS, and they said, oh, we enter it in MIDAS, and we put it on the agenda for the next quarterly quality meeting, and then we surface it there. And we said, and then what happens? And, well, nothing. We just surface it there, and it goes on the list. So that seemed to be prevalent wherever we went. There was a lot of this. We made a list, and we reported it at the committee. So that was one observation. We went to radiation oncology, and we spoke to radiation therapists, physicians. We spoke to technicians, and we got a whole education there. I think one of the classic pieces we heard there was when we said, what happened this morning? How many patients did you have scheduled? They said, well, we had a dozen patients scheduled. And we said, how many did you see? Well, we saw 10. Well, why did you only see 10? Well, because we had a couple of walk-ins. So I said, well, tell me about one of the walk-ins. Well, he said, well, this happens a couple of times every week. We get a call from the floor, and it's usually about a patient that had a total hip replacement 2 days ago, and they need some radiation, spot radiation. It turns out, which I didn't know as an endocrinologist, that there's a subgroup of hip patients that have some tendency to hypertrophic bone growth, and post-implant, if you don't do that, then they become problematic. So they said, well, this happens a couple times a week, and we just squeeze them in, which meant that then they were rushing to catch up the rest of the day, and we saw that as a potential safety interest because the minute you're rushing to finish out the scheduled patients for the day, there's an opportunity for something to go wrong. So we said, well, why don't they schedule that when they do the surgery? And they said, we have no idea. So we just did a quick investigation, and pretty quickly we found out it wasn't on the post-op orders. And we said, well, when do you know about this cohort of patients? And they said, well, we know when we schedule the surgery. So we called the surgeon's office, and we said, well, why don't you schedule the radiation 2 days post-op when you schedule the surgery? And they said, nobody ever asked us to. So that was characteristic of some of the things we started to hear. I can tell you now, it's about 18 months later since Roger and Kathy were on site, and they have not had a single one of those since that time. It's gone. And so as an interruption to the morning's work in radiation oncology, that's gone. And so it sort of is that little thing that was a quick fix that had a potential for a safety issue. We went to the OR and the PACU, and the classic one we heard there was apparently there's 2 setups for hysterectomies, and the surgeons don't let anybody know before, so they open the setup they think it is, and then if it's the wrong setup, the case gets delayed. And nobody had ever thought of putting it on the surgeon's card about which setup they wanted. In CVIC, we heard that on a regular basis, patients show up for an invasive cardiac procedure and they're still anticoagulated. And so that led to a whole series of questions about what was the process for getting the information about whether somebody was anticoagulated and whether they had stopped their anticoagulation and checking the night before, because that was a couple of times a week leaving them with holes in their schedule. So we went from forcing things into the schedule in radiation oncology to having breaks in the day and sort of breaking up the flow of work in the cardiac cath lab. In microbiology, we heard similar things about test results, but the really interesting one during the visit was in MRI. So there's a suite and there's a control panel, and then there's about a half a dozen MRI rooms around that. And Roger and Kathy and I were standing in the middle of all that, and Roger and I happened to be looking in the same direction. And we were there for over an hour, and about an hour into it, Roger and I kind of whispered to one another, why do they keep going over there to close that door? So we asked, we said, why do you keep closing the door? They said, well, we know there's a magnetic field in the rooms whether the machines are on or not, and the rule is the door has to be closed. So I said, okay, I understand why you're closing the door, but all the other doors are closed. And they said, well, that door keeps opening. We said, yeah. And then Roger said, well, have you called plant maintenance to ask them to fix the door? And they had this blank look on their face. And they said, we never thought about that. And these were the people that were sitting at the control panel, and every time they had to close the door, had to stop what they were doing, interruption, and go close the door. Again, a setup for a potential hole in the Swiss cheese and something to come back and forget where they were. And as the work has gone on, interruptions has become a theme in our findings throughout the medical center. So I mentioned about CVIC and the OR and radiation oncology. The last one in radiation oncology that we immediately found was patients coming in for radiation oncology and needing a CT scan, and they get there, and the way the program is in the computer, you can't actually start the CT scan until you put the diagnosis in. And regularly, patients were there with no diagnosis, but we knew what the test was. And so that was, again, an interruption in the flow of the day's work. And somebody, one of the frontline people, said, I never understand why they schedule these without a diagnosis. And we said, we don't either. And so that was a really quick fix, because now they won't put anyone on the schedule without a diagnosis, and so they don't have delays in the morning in radiation oncology. So I'm telling you really simple stories, but we believe that these simple stories sooner or later align into some big bad thing. So one of the methodologies that we've done is we've gone to other areas in the hospital, and it was first done in radiation oncology. We said we need a list of the things that are driving you crazy. And so the methodology we used there was they decided for 1 week, every day at noon, they would take 5 minutes, only 5 minutes, and they would reflect on the things that drove them crazy in the previous 24 hours, and they would just put the list together. And so in 1 week, they came up with 33 deviations. And then we did the usual thing of saying, okay, for each one, what's the potential for something really bad happening if that happens, and how often does it happen? And we scored them. And then we just started working off that list. And they've been working on that list now for a long time. And they knock off one every week or every week and a half. And the self-satisfaction at the front level in that area has been remarkable. It's probably the first time in my work at Cedars where the front line has really gotten so engaged, because they're kind of thinking this way and finding things and almost fixing them themselves. As Roger said, it's not about finding a big team to put together and get resources and get a facilitator. This is really work on the local level. So when Roger and Kathy and Steve left and they sent us a summary of the findings, they made these observations. They said, wherever we went, we saw talented, dedicated people who were really committed to what they were doing. They were rapidly able to visualize some other way of doing work when questioned by us, and they were also making heroic efforts, but a new way of work would be preferable. An example, back in radiation oncology, they said, well, classic, Friday afternoon, 2 o'clock, somebody on chemotherapy and radiation comes in with nausea, vomiting, and diarrhea. And I said, well, what do you do? And they said, we're really good at this. We can get an IV into them, get their electrolytes, get them spiffed up, and get them home by the end of the day. We've been doing this for a while, and we're really good at it. And we said, well, that's interesting. You really scramble well. You've got that well organized, and it goes back to what Kathy said earlier. This has become part of normal work. And then we said, well, do you ever interview the patient while you're fixing them in those few hours? Find out, did they fill their prescriptions? Were they taking their anti-nausea medications? Were they doing the amount of hydration? And they had this blank look on their face, like, we never thought of doing that. You know, it was all about getting it fixed. And so they started to do that, and then they found out all kinds of things about people that didn't have money to get their prescriptions, or didn't understand the instructions or the communication. And so they've been working on that part of it now, and those have started to go away. So the pride they had in their ability to fix it was something that they almost didn't want taken away from them. But then as we work through these things, they can give up that skill that they've developed out of the deviation. Other observations the team made when they visited was that daily interruptions are commonly viewed as normal. My great story on that is a woman named Sheila. Sheila was the secretary on a surgical unit, and when we asked her what drives her crazy, she said, I get interrupted all the time. So we said, for the next couple of days, every time you get interrupted, would you just put a sort of hash mark on a piece of paper? Let's see how often you get interrupted, and when you do that, tell us what you were interrupted for. So she did that, and each day she got interrupted about 30 times. What she was doing while she was getting interrupted was taking orders off the chart and entering them in the computer. So these were for tests, images, and so forth. And every time she got interrupted, there was a potential for her to make an error when she went back to what she was doing. It turned out that out of about 30 a day, about 27 of them came down to 3 things. One was somebody tapping her on the shoulder and saying, do you know the phone number to imaging, pathology, whatever? She had been there about 20 years. She knew every phone number in her head, and it was easier to ask Sheila than to sort of look. The second was families asking for blankets and ice, and the third one was physicians asking for charts. So blankets and ice got incorporated into hourly rounds. We took the 25 most common phone numbers and laminated them and glued them to every phone, and we gave Sheila instructions. If anybody taps you on the shoulder, don't give them the answer, point it to the card. And we worked on getting the charts back into the nurse's station. And so within weeks, about 26 or 27 of those went away, and she's rarely interrupted now. And she's actually taken to making comfort rounds because she has more time in her day. Wherever we went, people talked about being victimized by external factors. There was something out there. It was a physician, it was a nurse, it was a scheduling system, it was the computer system. A classic story there was in imaging when somebody would be sent down for a procedure and they would get moved off the bed, onto the gurney, down to imaging, and then there would be no consent. And then what would happen is the nurse in imaging would pick up the phone, call the nurse on the floor, and the conversation went something like, Mrs. Jones in here, she doesn't have a consent, I'm sending her back up, let me know when she has a consent, click. So we said, what would it be like if the conversation went, Mrs. Jones is here, she doesn't have a consent, can we just take about a minute to figure out how she got down here without a consent? And so it really became not the enemy on the floor versus the enemy in imaging, and we started to find out all reasons how people got moved down for invasive procedure without a consent, and now most of that's gone away. So, and again, patients were getting out of bed on the gurney, traveled through. Some of these were isolation patients, some of these were really sick patients, and they were making 2 round trips. So it became clear from the report and from the visit that in these stories I'm telling you were the seeds for the next big bad event. And they were things that the staff just thought were normal every day. Sheila thought interruptions were normal. Radiation oncology thought squeezing patients in was normal. The CVIC thought patients showing up anticoagulated was normal. So the idea was to start with the creation of small islands of stability in some of these areas we were working on. We committed with limited resources to work on 8 areas in the first year, and each area had to commit to fixing 1 thing each month. And I would make rounds either every 2nd or 4th week, depending on the area, with my team, so that we could sort of keep them on target and not let them sort of move into world hunger. So a year later, we're working on the surgical unit where Sheila is, the radiation oncology, the neonatal intensive care unit, the procedure center, which is an area in the hospital that does lots of procedures on both inpatients and outpatients, and they were constantly having no-shows or having patients walk in for things that they thought were scheduled. The ICU, the surgical ICU in 7 Saperstein, our patient complaint management process, so a non-clinical area that responds to compliments and complaints from patients and how they do their work, and then the patient safety area has been looking in how we do our work. So one on the surgical area was about diabetic trays. So our floors are sort of a horseshoe. And they start serving at one end of the horseshoe and they work to the other end of the horseshoe, and it kind of doesn't matter. You just get trays next. However, mixed in there are the diabetic patients who've had their blood sugars, need their insulin, and potentially could even get their insulin and not get their food. And when we asked dietary, why do you serve that way, they said, we've always done it that way. Nobody ever asked us to serve the diabetics first. So now the diabetics get served first, and the risk of hypoglycemia on that floor because of insulin and no food is pretty much gone. I told you the interruption story. That's a picture of the yellow piece with the 25 most commonly used phone numbers that's posted all over the floor so that we don't have people asking for phone numbers. And that's the story. Radiation oncology, I've told you about the hips, terminal cleaning, timeliness and coordination within the room was another thing that was throwing their day off. Patients who were infected and rooms had to be terminally cleaned, that got fixed. Bone marrow transplant patients who get whole body radiation are on a very specific schedule. And if there's a glitch in the software that throws the schedule off, that can really be sort of tragic as to when they actually get their bone marrow transplant. And that had been happening occasionally over a period of years. And so now there's a backup program run. If one fails, the other one is there. And so we don't have that problem of missing a viable bone marrow transplant. I think radiation oncology, from the stories I'm telling you, is an example of what's happening in most of these areas now, and that's that people are recognizing these things as they're doing their work. So they don't even need the 5 hours at noon, or the 5 minutes at noon. They just go out there and they recognize stuff and they jot it down. And then when we make our rounds, we talk about it and then we prioritize it into the work schedule. People are swarming over patients like the nausea, vomiting patients in radiation oncology while they're scrambling to fix it. And they're instituting tests of change in real time at the front line. And this is very, very different than what existed when we first walked in there 18 months ago. The procedure center that I mentioned is about consent. I just came from a workshop on games, and it was about communication. And this is sort of a good example of that. It turns out if the procedure center calls the floor and says, is the patient consentable, they really mean, will the patient understand the procedure I'm about to do and be able to sign and give me consent? And what the nurses thought consentable meant was, if I ask the patient to get out of bed and go to the bathroom, can they do that? And so they would regularly get to the floor with all the equipment, and the patient was not consentable. And again, delays and interruptions in the day's workflow. They're looking at issues around stocking and restocking of supplies, standardization, and requests for declotting of central lines. Along the issue of stocking in the ICU, 2 weeks ago, we discovered in the work that leads for patients being admitted to the ICU that get hooked up to monitoring are always a problem finding the right leads. They were about to order another $10,000 worth of leads and a big cabinet to put them in and lock them. When we got into the discussion, they figured out that housekeeping was throwing away the leads when they cleaned the bed when the patient left. And because leads were scarce, people were sort of hoarding them in all kinds of places around the floor. And they simply went to a sign-out thing. Every time you take a lead, you have to sign it out, and housekeeping has to sign them in. And the creation of a $5,000 cabinet and $10,000 worth of supplies went away. In imaging, I'm okay on time. In imaging, the culture was that if the phone rang, you would always go and answer the phone, and the tech would be interrupted. And so they just made it okay for the support staff to say, the technician's with the patient, I'll have the technician call you back. And it was another one of these interruption things that we saw as a safety issue. And about 2/3 of the time spent on calls and interruptions went away there in about a week or 10 days. So I'm going to stop there. I'm going to invite Roger and Kathy back up to the stage, invite you to go to the microphones and ask any questions or challenge us in any way you'd like.
Yeah.
Yes, sir. Can we turn on that microphone, please?
Thank you very much for the very interesting presentation. As I am a general practitioner, I would like to know if you have some experiences using the method in general practice.
Yes. I have been coaching several teams at Mayo Clinic in the community medicine program that they have, and it's highly successful in terms of surfacing defects. It appears as if this methodology works across the board with clinical, non-clinical, highly specialized units to very generalized medicine units. It doesn't seem to make any difference, and that makes a lot of sense because every one of the units that provide care to our patients, they all do the same thing. They all normalize deviation. They all look at hindrances or issues in their work that make their work less than smooth. They consider that just part of the job. And using this methodology has actually opened my eyes to the number of defects beyond what I could have ever comprehended. And to add one point to that, the defects are often such minor things, and I think Neil did a great job of demonstrating it. These would never be things that would come to the attention of the CEO or a vice president. These are things that are just bothering our frontline caregivers. And because no one really has the skill at the front line, nor do they have the permission, oftentimes these just become part of their daily work. And so the answer to your question is it applies everywhere, and general practice is no exception.
And I'd add to that, everywhere in and outside of medicine. So I'm famous for losing my hotel room key. And I do it every place I go, and I did it again this week. And when I observed that I'm regularly spending time getting another key, I decided that when I came into the room, I was going to put it in this spot. And so that, you know, it's these little things that drive you crazy in life. And it's not just about in medicine. It's about losing the car keys and forgetting to take your cell phone to work, and all little things that will work in the same way. We've all been accepting that we do these things that are interruptions in our life, and they're pretty soluble with not much inventiveness.
And I'd like to add two things. One is that it was striking every unit we visited. Roger's been out on other units. I've been out on other units. What was striking is the universality of people saying, oh, this happens all the time, and here's how we heroically solve it. There was never any thought to, could we make it go away completely? And you had to sort of begin to draw them out of that. The second thing is, if you go back to your organizations and you take stock of any kind of an adverse event that you would have had, or you've done a root cause, all of these little things are the things that add up into that. The schedule not being right, somebody not understanding a phone number, somebody being interrupted while they did orders. It wasn't maybe the single cause, but it was one of the factors that lined up without that. The third thing I would say is that when I went over the model in the beginning about the maturity model of improvement systems and reliability, Neil was describing several units that were down there at that buffer level. They were actually taking stock of things and sort of hoarding things and keeping things and not trusting what was out there because they didn't feel that they could trust it. And these units that he has described are now really up there at level 5 or even probably level 6 in learning to see and solve their problems, make it completely go away, and start again on the next one.
The other thing we've done is, now that we have a cohort of units, we have a quarterly meeting, and we invite people to present their work. So Sheila came and talked about interruptions, and meeting goes for about 90 minutes, and we spread the information to other units. So unit secretary from another unit heard Sheila speak about it and picked up an idea there, or something from the procedure center, and so we're spreading into other areas of the organization through this sharing, which is done by presentations by frontline people. I don't even say anything at the meeting.
And that's a great illustration of that top level of improvement. So it's see, solve, share, and lead. And Neil has now become a leader that begins to sit back, watch what the frontline staff is doing as they learn to see and solve problems. He's created an environment where they can share them with each other and learn from them. And his leading is now not pushing them, but actually standing back and listening and facilitating what they've done.
And I think one more comment would be worthwhile on this particular topic. What we see is the value of making sure that you scope this project ahead of time so that one or two people can work on the solution to the problem. It's very easy for this to escalate to a much larger project than you want. So the way they handle it is, let one person like Sheila work on the problem, given the ideas that are being generated from the front line. Once they show some success, then spread it to somewhere else, as opposed to trying to solve the problem at a much higher level where you try to make everything homogeneous for every one of the units. That usually does not work because each unit has their own unique characteristics and they have their own unique solutions. No other questions?
Yep.
Oh,
Over here.
yes?
Interesting talk, thank you. You've said that safety hasn't improved over the last 10 years, but there's obviously been lots of initiatives and measuring it with global trigger tools and the like. Has anything, obviously it's early days for this, is there been any obvious decrease in harm from the initiatives that you've put in, or is it more that it's much easier for staff to work?
That's a great question. First of all, you are absolutely correct. Using the global trigger tool, which we've had for approximately a decade now, and a study which we reported in the New England Journal, shows that there has been no improvement at a high-level measure, such as the global trigger tool, in the last 10 years. That's not to say there hasn't been improvement. If we were to look, for example, at ventilator-associated pneumonias or central line infections or hospital-acquired infections, if we were to look at those unique defects at a high level, we could see significant improvement. The problem is that in a given hospital, there are, for every 10,000 admissions to your hospital, there are 4,000 adverse events. Now, you could get rid of every central line infection and every ventilator-associated pneumonia in a very dramatic way in your hospital, and the denominator is so large that the actual safety in your organization would not be measurably improved. So this is what we're finding across many countries as we start doing this work. So the idea being that, is there another approach? If you looked at the model we put up there, our approach right now is primarily top-down. Our approach is saying, here are 4 projects that we want to do this year. What this methodology is attempting to do is saying, can we complement the top-down with a very vigorous and robust bottom-up approach to the problems of safety in our organizations? We have not shown improvement on the global trigger tool scale using this methodology. We've just started using this methodology. So the thesis, however, is that we, in order to see substantial change in that global trigger tool measure, we're going to have to do both top-down and bottom-up improvement ideas.
I think the other thing is that as I talk to the people that are doing this work, the people in radiation oncology and Sheila, and you ask them about their job satisfaction and whether they feel empowered to make it safer, they smile and they say yes. They are happier in their jobs because they don't feel sort of victimized as much as they did before. And I think that one of the goals of this work for me is to get people to feel less hammered by their job every day and more able to make a contribution to the safeness of the institution. And as I interview them, that appears to be pretty universal.
Any other questions? Thank you very much for joining us today, and please download the methodology so you can get a very clear description of what you might need to do if you were going to try this work. Thank you very much.